Okay, this is an example of segmentation to the extreme. This is a diabetic patient with a diabetic tractional retinal detachment. And I always like to start out these cases by separating the peripheral and anterior vitreous from the posterior vitreous, if I can. Now, if a patient has very adherent mid-peripheral vitreous, then I'll start to work posteriorly and use that segmentation plane or that plane to actually elevate the mid-peripheral vitreous. In this situation, the mid-peripheral vitreous was up, and so I like to just get in and get my bearings by doing peripheral vitrectomy here, clearing out the hemorrhage. And once I've got that cleared out, then I start out working on my segmentation. Now, what I'll use first here are some max grip forceps, and I just go for the easy target, picking up some of the fibrotic neovascular tissue. Patient's been treated with anti-VEGF about a week or two before, and elevating and creating a plane. And then I use this 25 gauge bevel cutter, 10,000 cuts per minute, to actually do a really nice segmentation across here. And I'm just looking for the easiest way to separate these fibrotic islands to create smaller islands that can then be more amenable to having the cutter remove them. Some of this fibrotic tissue is very entwined. Some of it's coming up very nicely with the cutter. Here you can see the cutter does such great work at pulling up this fibrotic tissue and cutting it right in. Here I take the tissue and I try to lay it back over on itself so I can not only pull in the plane of the retina, but I can also see what's going on underneath it. And as I'm looking at this, I'm trying to find a plane for my cutter. Here I use a little bit of bimanual technique, probably not necessary in this situation, to just create a plane there. And now I'm finding more and more areas where I can actually sever and create these islands of fibrotic tissue. And once you get them down to about a disc area or less in size, then you can just kind of attack them with your cutter at the edges. So here I'm looking and I find one last little piece. I did create a couple of small breaks when I was peeling there and cutting, and so I go and diathermize those areas. Here I'm creating another plane utilizing my cutter as a pick almost to create space, and then using it as basically vertical scissors here. Once I've got it in this manageable island, now I can just let the cutter do its magic by getting to the edge or on top of this fibrotic tissue and just letting it fall into the cutter itself. I've got my pressure up at 60 to control any kind of bleeding. Blood can really make these cases miserable, so you really want to be good at trying to control that hemostasis. Watch how beautiful the cutter is as it works along the edge of this elevated vessel. And I can go right up to the vessel and just take this fibrotic tissue right off of the vessel, and the cutter is just perfectly selective for the fibrosis and not the vessel or the underlying retina. Now we're working along the superior temporal arcade, and I'm using that bevel cutter to my advantage, finding a small little crevice in space. Some of these areas of vitreous traction that have not become opaque and fibrotic can be very difficult to visualize, and so sometimes you can just watch for traction on the retina to tell you where you should be. Here we're attacking it from a little bit of a different angle. This is right-handed, and I'm working kind of in a backhand motion. I find that the easier plane is with the forehand, where I can actually see a little better what's going on. I got away with one right there. My cutter just kind of took off on me. Luckily did not create any breaks as I created that nice segmentation avenue there. Watch how nice the fibrosis just falls into the cutter, and once you've got into these small little areas that are elevated up, you can just let your cutter go right next to them and just trim them right off. And then we'll continue to segment some of this less opaque vitreous here down, and you can see just how much the retina relaxes when you actually have completely severed that vitreous. And then finally, our one last piece, I'm going with a backhand motion here. I can see my cutter tip. I decide to work a little bit more off to the side to just try and get things done, and it just comes off so beautifully. One of the things that can really spoil a great case like this is when you have oozing or bleeding. You definitely want to take a lot of care and diathermize. Here we're aspirating the hemorrhage up with a soft tip. Diathermizing, but not too close to the optic nerve, is really critical. Cutting a little bit of the peripheral vitreous just to make sure we've gotten a good, complete, full vitrectomy. And I'm going to use these two little breaks along the inferior temporal arcade to my advantage, and I'm going to drain through those to try and aspirate out any chronic subretinal fluid. I know that I've drained them flat because I'm able to get laser all the way around those. Thank you so much for watching.